think it's slide 30 that we're going to be starting at. All right. Any questions so far about how I'm going to run the show? No? Good? Understand what we're going to be going through? All right. Let's talk about teaching.
It's really hard to see.
You don't like my colors?
No, it's the lighting.
Oh, yeah, much better.
I'm sorry. I changed that this year because I didn't. I'm sorry. That don't really show up good, does it?
None of them do that. It's not just yours.
Oh, I just think that
Last year we had to shut those back with the blinds.
yeah, they're shut right now. So if you might need to shut those too.
Those are the blue.
At least if you have your computers or if you print them off, you got them right there in front of you. That'll help a little bit. Baby? All right, teaching. It's not because I just came up one day and said, I think I might need to teach my patient something. There's lots and lots of research-based information that says these patients need information, and we need to know how to give them that information. JCO, you ever heard of JCO? It's a big old group of people that come in and they tell everybody how to run the hospital and how to run the nursing home and how to do everything. As they started looking at stuff, they thought there's not enough teaching going on or documentation of teaching going on. We can say all these nurses go in there and they told this patient that they needed to check their blood pressure 1 time a day. And then they walked out. That patient had no idea how to take their blood pressure. But I told them how to. So they're thinking, okay, we got to prove that we did this teaching. So we got to provide some evidence that the patient received the information and they understand it. That's pretty hard to do, isn't it, sometimes? Y'all are sitting in this classroom, and I'm giving you all information, and you got to start processing. Okay? So and it's hard sometimes. So I've got to prove that some way I actually gave that information to my patient, and they understand it. That is a standard that I have to abide by. And it's not just because JCO said it. It's because that patient has the right to have that information. It is my legal responsibility to make sure that that education is given to that patient and that they understand it. I'm legally accountable for making sure that I teach my patient what they need to know with the new disease process that they just went through, all this information. One of the biggest things that you're going to be teaching patients is you've got a newly diagnosed diabetic and they're going to have to give themselves insulin. There is lots and lots to know about giving themselves injections. Okay? First of all, think about all the things that they're going through when they just get that diagnosis. That's a big disease process that affects a lot of different organs, doesn't it? And it's vital that they understand the things that they need to be looking for. So we have lots of responsibilities to make sure that we teach that. But remember, it is our responsibility and the patient's responsibility, or their right, to be able to get this information. Joint Commission has increased their, just like I said, they've increased it, said you've got to give them this information, you've got to give this information. But think about all the different levels that this patient, or the patients that we take care of, come in with. One of the first things that you probably saw when you were in putting your data in, they asked your partner, whoever, what is your educational background? Why is that important?
Determine whether they can read or write, and they'll be able to comprehend what you're telling them.
Maybe they can't write. Maybe they can't read. So I've got to know what their level is so I can provide information that they can understand. What do you think one of the biggest barriers that we're coming into contact with now? Language. Very, very important. Different cultures. And that's why all the hospitals and all facilities are getting translators that are there for us to utilize. We have got to utilize. Just to give you a little example, my daughter's a third grade teacher, and she's been having trouble with one of her little students that just speaks minimal English. Minimal. Well, the other day, my daughter caught her cheating. And she said, does your mama speak English? And she said, no. I'm the one who speaks English for my family. And she has very, very little English language that she can speak, and she's in the third grade. So they had open house the other day, and the mom comes in with a little girl. So my daughter's trying to communicate with this mother, and she can't speak English. So my daughter's saying, she cheated. And she was going, yeah, yeah, with a big smile on her face. And, yeah, like the mother didn't understand anything that Ashton was trying to tell them. The good thing about us in the hospital setting, we can pick up the phone, can't we? I need a translator up here. I'm not getting the information over to my patient to where they fully understand what I'm trying to teach them. Poor Ashton was not in that situation. She was just like, what do I do? This mother doesn't understand what I'm trying to tell her. And it's sad. It's sad. I keep saying I'm going to learn how to speak Spanish in some way. So if anybody can speak Spanish, please teach me. Because I feel so inadequate sometimes that I can't get that information over to my patients. And that bothers me because they deserve that information, and they deserve to be able to process the information the way that they're educated. So know that you've got to look not only at the information we're giving them, their educational background, do they speak English, those kind of things are all, and it's really hard to do sometimes. But what I'm telling you as a nurse, don't stop until you get the resources that that patient needs to adequately get the information they need. Okay? There's all kinds of resources out there that you can get into, and you can holler at people and say, I need help. My patient, because you know what? It's all about that patient. And you'll hear me say that 150,000 times. It is all about them and making sure that they get the information. Some of this stuff is just straight out of the book to make sure that you are looking at some of the areas that are important. Now you can read this all day long, but really, what is an attribute of learning? What does that actually mean when I read through this? Because every time I look at my patient, I need to look at some of the attributes that are going to help me in educating them. What kind of things do I need to look at? Do I expect them to get it just like this? No, they're going to take it in. They're going to process it just like, and I don't know if I really like this word evolutionary or evolution. Yeah, evolutionary. I'm not really sure I like that term or not. But it really is a process. And it takes steps by steps by steps to get that patient to understand it. Another thing that you need to know is you need to look at their emotional status and their emotions as they are dealing with this information. We also need to look at experience. What has this patient been through? Have they already been through 15 surgeries? Have they been through this information? or some of this information before, and we just need to reiterate it. So you really got to actually know where the patient is before you start attributing to their learning process. All right, and I'm sure you've probably already gone over the different domains of learning, but you do need to know that we don't just look at one aspect of the domain of learning. A lot of people think, oh my gosh, it's just a cognitive thing. I can't get this cognitive thing. In other words, I can't think. It's what you might think when you're given all this information that we start throwing at you. I can't think. But you also have to look at the other aspects or the other domains of learning that will contribute to the thinking part of it. The cognitive part is the thinking, knowing it, comprehending. One of the biggest things you're going to have to start learning how to do is apply the knowledge. I'm giving you the information, and I'll tell you in just a little bit different ways you can help a patient apply that information. Not give them a test, right? Like we do y'all. So the cognitive domain is the actual knowing and thinking. Affective, I got to look at how they're feeling. That really is not good, is it? I'm sitting here looking at it. I don't see it very well either. They're affected. They're feeling. How are they feeling about this? At this point in time, I've got to look at what is my major goal when I'm wanting to teach somebody something. I got to make sure that my goal and their goal is what? The same. I got to make sure it's the same thing. So if I want them to learn 15 things over here, and then I look and see what their goals are about learning, they may not be the same. So we got to work together to make sure what is the major goal. And the other thing that you'll see, are they really interested? One of the things that's going to frustrate you more than anything else in nursing is that we've given this patient all this information, and we'll see, and you'll see this as we go through. You have a patient comes in this week, and you went through all this teaching with them, and you felt like our goals were met, and then 3 weeks later they come back into the hospital. They have not done one thing that we asked them to do. Is that my fault? No, it's not my fault. Did I provide the information for them? I should have, but it's their decision to take that information and go with it. It's very frustrating as a nurse to see that. It is. But we've got to really look at where they are. If I see a patient like that comes in time after time, and it makes me so angry when I hear the nurses say, oh, they're a frequent flyer. You ever heard that term? Drives me crazy. There's something that we need to do to help that person not be a frequent flyer. So if I see somebody coming back and forth from that hospital, I've got to still start looking at the ways that I taught him before didn't work. So I've got to look at other ways to integrate teaching. But did I really thoroughly go through his educational background? Did I really go through if he was game, or did he buy into this? But one of the biggest things that you're going to see is, did they have the resources there? Were they financially set? Let's say I taught him everything he needs to know about diabetes, and I told him how to do the injections, and he knows, and he was giving me all this return demonstration. But when he went home, he didn't have insurance. He didn't have any resources to go buy that equipment. So I've got to look at this patient holistically and make sure, and that'll be my time. If he didn't have the money, if he didn't have the insurance, what do you think I'm going to do? I'm on the phone, and I am calling somebody that works with patients that need help financially. Do you know what that is when nurses start doing that? for patients when they look at all that? Do you know what that really means that we're being for this
Compassionate.
patient?
Compassion.
I think I heard it.
Compassion.
Advocate. You have got to be an advocate for that patient. You've got to look at them holistically and be an advocate for them. The other thing is psychomotor. What do you think we've been doing with physical assessment in here? We gave you the cognitive information, right, to make you start thinking, right? Then, hopefully that your interest and your goal are the same thing as ours, for you to learn how to do a physical assessment. Then we took you into the lab, and what did you actually do? You applied that information, and you started giving me information, or the psychomotor part of it, whereas I watched you place 8 them in, right? That's a psychomotor. Like our diabetic, I gave them the information about diabetes. We set our goals. Then I actually have to see him return that demonstration to me to make sure that he adequately can do that psychomotor skills. You've got to take into effect that patient's physical ability. What if they have visual problems? I got to worry about getting them something, a magnifying glass or something for them to see the actual syringe, for them to draw up. So I've got to see them do the skill to make sure that they're not having some kind of deficit there, because or they can say, I can't see the syringe. So we either need to worry about getting glasses or getting a magnifying glass. You see what I'm saying? I've got to look at them in every aspect, those 3 domains when I'm looking at teaching. I've got to make sure that they get it and that they can return that demonstration. That's exactly what we're doing to y'all. We gave you the physical assessment information. Now you've got to prove to me that you can do that. So all 3 of those domains are going to help in the learning process. Okay, you've got to include all 3 of them. Now, I did talk about, and I don't like to spend a lot of time on the different theorists. Excuse me. Because that's one of the things that you can read. It's not going to change. Pavlov, everybody's heard Pavlov. Okay? What I want to do is I want to show you when you demonstrate using behavioralism what a nurse actually does. So you can look at Pavlov and you can see all the conditioning things that he did. But as a nurse, and I'm trying to plan my care for my patient, I need to look and see what ways I can do that to help them understand the information. One of the biggest things is I need to make sure that they have significant time to practice. You can't teach somebody how to give an injection in 2 minutes. So when you are planning your teaching, you need to make sure that you have given them adequate time. You've got to stop everything else. All your other patients are taken care of. And I've got to know that I can sit down with that patient and talk to them and make sure that they have I'm getting choked up here. Adequate time to practice. It's the same thing that we're doing with you guys. How many times have we opened that lab up for you to practice? Bunch. Can I make you go do that? I can't, but I need to make sure that I'm giving you time to practice that. And you've got to do the same thing with your patients. Give them adequate time. They need to keep on, I need to keep asking them questions to make sure and verify that they understand what I'm saying. Repeat back to me how you understand this. Okay? The one thing that happens a lot of times is when like I was talking about the little man that came back and came back and came back, that's called trial and error. And that's what's going to happen a lot of times. You may get, it is frustrating for us, but it's the same thing with nursing skills. I can tell you exactly how I do an assessment, but it may not work for you. I've been doing this for 25 years. Do you not think I've done lots and lots of trials and errors? Lots and lots. And that's okay, as long as we learn that this is not the way I want to do it. I need to try another way. Give that patient that opportunity to have a lot of trial and errors too. What works better for them? You also have to look at the patient's different learning styles. Every one of you have a different learning style. Like, I think Jennifer. Yesterday, I looked at her and I said, you have got to be a visual learner. Because she had her assessment drawn out. She had a little body and, you know, had a head, and then she had all this stuff that she's supposed to assess with the head, had it all drawn out. Because that is her learning style. Let me just tell you, when you are looking or you're with a patient, ask them, what ways do you learn better? I had a student a couple years ago that I sit there and talk to her for 30 minutes. Me and her, I mean, she was struggling in something. 30 minutes I spent with her. And finally, I could tell she had that stare. Like, I said, "You're not getting it, are you?" She said, "No." I said, "What kind of learner are you?" And she said, "I'm very visual." So I got a piece of paper out and I started drawing some of the stuff, which I'm not a very good drawer. Then I drew it. She got it just like that. So it's vital for you to ask your patient, how do you learn best? Is that one of the questions that you ask in that assessment? How do you learn best? If they say, I am so visual, then you've got to go get some visual aids. Okay? If they say, oh, I'm auditory, just tell me I need it, then that's when you need to talk to them. Okay, so you've got to figure out what works better for them. The cognitive person, you can read through that. I'm not going to go through that. As a nurse, how am I going to help a person that I think I'm finally getting this cold that I've been trying to get for 3 weeks. How do I, as a nurse, when I'm using this type of theory, what do I need to listen for or look at? One of the biggest things that as I'm teaching, I'm looking at one statement in here, and this is one thing that you'll hear a lot from me. Encourage positive teaching, learning, relationships. How many people got high five yesterday from me? I know I get high five. Is that a positive? Now, I'm not telling you to go give your patient high five, because they might be saying, yeah, what the heck are you doing? But as I'm trying to teach somebody and teach y'all, I constantly am trying to say, oh my gosh, you did such a good job. Tell me your name. Just back on back. Tyler. Yesterday, Tyler, I could have done cartwheels because he was able to, I don't remember what you said. What did you find yesterday? You had COD. What did COD? What did you hear? I got so excited. Right. He heard an actual extra sound. He heard a murmur. I know some of you did too. Kayla did too. And what was I doing? I found it. Woohoo! Woohoo! We've got to give that patient some positive feedback there, because if they get that, didn't that make you excited? Didn't that give you a little bit of self-esteem? And the other thing it looks at is, you know what, maybe I can learn this after all. Maybe I can do this. And I mean, everybody likes that feeling that, oh my gosh, because when you walked in the door, you started nursing school, you were probably thinking, oh my God, I can't do this. This is crazy, I'm quitting, I'm getting out of here. I cannot do it. But when you hear, and the patient's the same way, especially when they've been given the big diagnosis of diabetes, and that they've got all this information to gather, give them some positive feedback. say, you know, you can do this. You know, I know you can. And I'll give everybody a high five and let you know I'm glad you learned something. We've talked about the different learning styles. One of the things we haven't talked about is developmental stages. Now, obviously teaching is going to be a little bit different for my young children than it would be for a middle-aged person. So what you've got to do is you've got to look at their developmental stage that they are in. One of the first things that I ask mom or parents or, you know, whoever's there with that child is tell me some terms that they use for different things. One of the things is when they have a bowel movement. Now, if I go into a patient, a 3-year-old's room and say, did you have a BM? Do you think they're ever going to understand what I'm saying? No. So I asked Mom, tell me what term do they use when they go to the bathroom? So as I'm talking to them, I'm going, did you stinky? You know, because that's the term that they understand. The other thing is, I mean, I always use this term myself, but it's really funny because I've heard nurses say this to pediatric patients. Did you void today? This 5-year-old saying, what in the heck is she talking about? Voiding? No, I don't know what voiding is. You know, use terms that they understand, that developmental stage that they're in. Other things you need to look at is when you're teaching someone, and I hear everybody thinks old people can't hear, and they usually can. So if you ever found yourself when you go in and talk to an old person, hey, what you doing? You know, screaming at them because you think there's some reason that they can't hear. So look at them. What problems do they have? Yes, and you say, you know what, I can't hear as well out of my left ear, so I'm not going to get on the left side. You know, those kind of things. You got to look to make sure that the environment for learning is very conducive. And one of the biggest things that I will always stand behind you, I will support you 100%, is I want to make sure that your learning is conducive to learning. This environment is conducive to learning, because I can tell you, I can't learn if there's a bunch of noise going on, or if I've got 25,000 things going on and I can't learn that way. So you need to ask your patient those types of questions to make sure that that environment is going to be where they actually take in everything that you're giving them. Humanism, that's Maslow. Have I told you yet? You got to know about Maslow. Have I told y'all that yet? Maslow is going to be your best friend when you learn Maslow. You know why? Hierarchy of needs. And guess who really, really likes Maslow? NCLEX. NCLEX loves Maslow's. And they will encourage you to every question that has anything to do with the patient and the needs of their patient. It is going to be based on Maslow's hierarchy of needs. So I'm telling you right now, you have got to learn that, and you have got to understand it, and we have got to start applying it. You will be given situations that will be, the patient has all these things going on, and you will have to say, what is the first thing I would look at for that patient? And if you're going to base that answer on Maslow's hierarchy of needs. Okay? So he's the man. I think we've talked about a lot of things. One of the things, what really concerns you about teaching someone something? What do you really worry about when you're starting to teach somebody? They understand. That you're going to bore them? Yeah, I sort of feel like that sometimes. That's why I'm up here going, yeah. you're going to for them. That might be something. Will they remember it? Yeah. If they're going to ask a bunch of questions, but what would be, do you have the right answers? That is one of my big, I mean, I'm doing this 25 years, and what if this patient asks me something I don't know what the heck he's talking about? Or how to answer it? How are you going to handle that situation?
I don't know, but we'll find out. I'll look it up.
Exactly. I don't know the answer to that, but I will be glad to go find that for you. Do you think you're going to know every answer that patient's going to ask you? Are you going to BS them? No. Are you going to try to BS me? Yes. Yes, you will. I know. You try to BS me, and I'll look at you and say, hey, look up. You don't know what I'm talking about. But anyway, but we're going to learn from it, right? Yeah, do not ever. You can try to BS me, but don't try to BS that patient because they deserve the right information. It is okay for you to say, I don't know the answer to that, but I will be glad to go find out. I can get on the phone to the pharmacist. Well, there's a new drug. And I looked at my drug book and it's not in there. What can I do? I can call the pharmacist. That's one of my resources. Help me. This patient's on this drug. I don't know anything about it. Can you give me some information on it so I can share with my patient? Admit to them you don't know something. The other thing is when you tell them that you're going to get the answer for them, you go back and you give them the answer. Don't say, oh yeah, I'll find out, and, whatever, and then never go back. That is unprofessional, and that's not going to be tolerated. You've got to provide that information. Let's say it may be a situation that we're getting ready to leave clinical and you didn't have all the information right there ready for you to provide. You need to go back into that patient's room, tell them, you know what, I have not been able to find that information yet. I have passed it on to your nurse, and they are going to make sure that you receive this information. Then you go tell your nurse, look, I've got this information coming up from pharmacy because I've got a visual learn. I've got somebody who likes to read to learn. I've got all this information coming up from the pharmacy. It hasn't got here yet. I'm getting ready to leave. Can you make sure that my patient gets that? Okay? Don't leave strings hanging. Always make sure that if you tell a patient you're going to do something, you need to do it. Okay? And don't be afraid to say, I don't know. Because in this point in time, there's going to be a lot of things you don't know. And that's why you got to utilize me and utilize our resources that are out there. Okay? To make sure that they get what they need. Okay, we've talked about different factors. We've talked about age. Sometimes if you'll notice with me, I sort of get a little ahead of myself. So I have to backpedal just a little bit. Things that I've looked at that affect our learning, our age and development, we've talked about that. We've got to look at the development. Another thing that you look at, are they really motivated to actually learn? Do they really, sometimes y'all come in class and you're like, oh my God, I got to listen to Miss Walker another 3 hours, Are you really going to learn a lot then? No, not really going to. And you got to look at that patient. What if you go into that patient's room and you're talking to them and you've got your whole plan of care right there and you got all these things to teach them and you've got your paperwork and you're ready to go, and you go in there and your patient is crying. Are you going to say, now, excuse me, you need to stop crying right now because I got to carry out my plan of care because Miss Walker says this is my plan of care and this is what I've got to do, and now you need to quit crying. Okay? Because sometimes, believe it or not, that's going to be your mindset sometimes. It is going to be your mindset, I promise you it will. But you think I'm kidding y'all, I've seen a lot. I've seen actual students say, my patient was crying and I just sit right down and told her all about diabetes. She's not probably motivated enough to learn anything at that point. You got to look at your whole patient. You got to be right there with them. That's not going to be a good time to sit down and teach them anything. And that's another thing with readiness. Are they ready? I like to get people actively involved when I teach them. You know, don't sit there. And I know I had nurses when I worked in labor and delivery, and they would have this discharge sheet, and they would just sit there, not look at the patient, nothing. Okay, you know that you're supposed to come back to this. You know that if this happens, you need to do this. You know, if you need to do this, and, you know, okay, call the doctor if this happens. Hello? You know, talk to the patient. Once you go over, don't give them 15 things to know. Start with that first thing. Talk to them. Look at them. Communicate with them. We'll talk more about communication later. But make sure that you're giving them small bits of information at a time and have them actively involved in the learning process. Get them, you know, show me the syringe. Show me what you're going to do. You know, have them actively involved. The other thing you need to give is feedback. Don't y'all love feedback? You know, as soon as you have a test, you expect the grades to be up in 30 minutes, and then you're ready for test review for you to know what you did wrong. Right? Patients are sort of like that too. They want the feedback. They want to know, am I getting this? Or am I not getting this? And you owe them that to tell them, to give them some feedback they need to do. You are never, ever to be judgmental of anyone that's learning. Okay? Now, I know that you will see this in the hospital setting a lot of times. If I go into the patient, I spend 30 minutes with them and talking to them about, you know, their goals and their learning and all this kind of stuff. And then you'll hear a nurse come out and say, you know what, I spent 30 minutes with her and she didn't learn a darn thing. You know, she is so stupid. Why can she not understand? That happens a lot of times. You're going to see that. It is not your place to be judgmental. If it takes you an hour to teach somebody how to do something, then you are going to spend that hour and you're not going to sit there and say, they are so stupid. Because they don't deserve that. I always say, I have and my brother always says, she's retarded. And I'll say, no, she is not retarded. She's mentally challenged. Okay? It means that she can't learn as quick as somebody else. It may take me 25 times to learn how to do something on a computer. Because I am not real smart when it comes to those computer things. And I would hope that whoever's teaching me would be patient with me and understanding that I just can't get it. Okay, so don't get in there. You know, you're going to talk junk about your patient. Wait till you get home and go to your dog and talk junk to your dog about it. Okay, there are so many, and unfortunately, we see so many things happening at this same time that patients are just not getting it. So we've got to look at other ways, but please don't be judgmental on them. Repetition. It may take you 15 times. How many times have y'all tried to listen to the apical pulse? Hundreds of times. Okay? And you know what? You're going to do it 100 more times. But you know what? Patients need that repetition as well. They need to keep stabbing that orange when you're teaching them how to give an injection. They need to do it over and over and over and over again. Environment, we talked about that. Culture, we talked about that. Psychomotor, we talked about that. One of the things that I want you to also realize is when you're planning what you need to teach to someone, please go from simple to complex. That's exactly what you're doing in this program right here. We are taking things very simple and we're going to move to complex things. Okay? So you need to make sure that you do that. All right. Y'all ready to take a break? All right. Take a break. All right.
Here it is.
15 When you look at teaching someone, repetition is in that. So I repeat myself a lot of times, but I think I've already pretty much hit the majority of this when we're talking about looking at that patient and see if they're actually, the assessment that we're going to do to see if they're actually ready to receive this learning experience. The other thing I don't think I ever mentioned earlier was you need to ask the patient at the beginning, tell me what you know about whatever. You see what I'm saying? In other words, if, let's say, Erin's a diabetic. So if she comes into the hospital, and she's been a diabetic for how many years? 20 years. So when I need to look and see what things does she already know, because if she's been doing this for 20 years, I don't need to sit down here and say, diabetes is, and start doing, very simple stuff. Show me how you give, here's how you draw up insulin. I need to know what their needs are as far as, are they a newly diagnosed, or have they had this diagnosis for a long time? So you really need to look and see where they are first before you start, bond and not belittling them. But it makes them not have, you know how you are. You don't want to sit in a classroom and you've heard this information over and over and over again, and you just don't want to hear it anymore. Okay? Patients are like that too. I'm not going to have to start at the very, very basics with Erin because she's got a lot of that knowledge. You need to make sure where they are. We talked about the age. Do they really understand that they've got a learning need? I don't know if I really like the way if it's a problem, but do they really understand that they need to be taught something, that they need to learn something? And that you can go straight in from that and start setting your goals. What kind of goals do I want to meet for this patient as we're teaching? We've looked at culture, economic. We talked a little bit about that a while ago. As we go, if we realize that they don't have financial assistance, we will go get that resource for them. The other thing that you really need to look at as well is what type of support persons or people do they have right there. In other words, if I was a newly diagnosed diabetic, and I use diabetes all the time, and I'm sorry, that's just what I use, I want my husband to be right there with me. Because even though I've been a nurse for a long time, there may be something that educator is going to give me, because even though I'm a nurse, I want to be educated as well. There may be something else that I'm not familiar with. There may be a new procedure, new something else that I want to be educated. Just because I'm a nurse, don't think that I don't want to be educated. And when I was in the hospital a couple years ago, about 6 years ago, I had a breast reduction. And I abscessed my incisions. I had no one that assessed me, no one that changed my dressings, and no one tried to teach me anything. And you know what their excuse was? I was a nurse.
You're still their patient.
I'm still a patient. And even though I've been a nurse for a long time, I still, if I see, because you're going to take care of like nurses, I still deserve the right for someone to sit down and talk to me and make sure that I have got the adequate information that I need. It was so, some of the care that I got, and I'm sure it's because I was a nurse. When you learn more about medications, one of the biggest things that you got to do is you got to identify your patient before you give any medication. And while I was in the hospital bed, I had a medication that was due at 2 o'clock in the morning. Well, her excuse was she didn't want to wake me up. So when she came in to hang my IV antibiotic, I immediately said, my name's Leanne Walker and my birthday is 4/7/64 and I have no allergies. And she went, oh, I thought you were asleep. I don't care. That is part of the medication administration that you do. The same thing with teaching. That patient deserves every bit of teaching and information that I can give. So doctor, nurse, whatever, you still need to give them the information. And the other thing is, have someone, I know like when my dad was in the hospital all the time, if any teaching was getting ready to happen, my mother would always say, can you wait till my daughter gets here? Because my daughter has a little bit of knowledge and she needs that support person, because it's, I mean, you've been to the doctor before. You know how sometimes you're like, you didn't hear anything that they said. You know, and you get nervous. The patients are the same way. So hopefully you've developed a good relationship with them and they have someone else that's there, that's listening, so that will be support for them as well.
Is it acceptable, like, if they are sleeping like that, with their armband, you need verbal?
I need verbal. You can scan, and I need them to tell me. Yeah, and you'll hear me preach a lot. I teach meds, so you hear me preach that a lot. All right, teaching strategies. There's different things that you can do, and we've talked about this as far as looking at their learning styles. A simple explanation will be fine. One-on-one discussion is fine. One of the things that you'll see in psych, when you get the psych rotation, they have a lot of group discussions. And patients may be more apt to that, to learning better in a situation where everybody that's in there that has similar issues going on. So that's another way that you can set up and looking at their students, their teaching strategies. Demonstrations, another. Practice. Another thing that is very, very, very good about the hospitals around here now is they have information that you can print off about their drugs, about their medications. So if they, you know, even though we've talked to them about their medications, if they also have things that we can print out for them to take home and they can read, or they can have a support person that is able to read. We always want to be able to include information that is printed so when they get home, they have that with them. Now, one of the things that nursing students love to do is they love to get on the internet the night before they go to clinical. And they got a patient that's got diabetes, and they're going to go and they're going to print out 1,500 sheets of things to give because they want to teach that patient everything they need to know. I have no problem whatsoever with you searching the web and finding information that you want to give to your patient. The thing you have to do first is you have to show it to your instructor before you give it to the patient. Because there is so much out there right now, we have to make sure that this is a reliable source and that you're giving the patient the right information. Okay? So, yeah, if you want to do that, that's fine, but just make sure you go through your instructor before you give anything to a patient. The good thing now is the hospital has things that we can print out for them. And the pharmacy also gives them stuff they can print out with their meds. So I am all for visual stuff. All for it. But just make sure that you let us look at it before you give it to them. Also, ask them, with everybody being on computers now, ask them, do you have access to a computer? Do you know how to get on a computer and search the web? If so, this is an excellent website you need to go to. Okay, lots and lots. That's an opportunity for them to get further information. One of the biggest things, and we'll talk more about this when we get into communication, is you've got to build a relationship with that patient. They've got to have a trusting, I guess is a good term to use. They've got, because there's a lot of times I know that I've seen nurses, I'm like, you know what, I wouldn't trust anything she's ever told me. You know, I will tell you that the unit I'm on, when we go to clinical, there's a nurse there that doesn't carry a stethoscope. I think I told y'all that. Yeah, he doesn't carry it. Yeah, doesn't carry it. He's on a respiratory floor, no stethoscope. If he was to sit down and teach me anything, I wouldn't believe a word he said. Okay? So I hope and pray that you will not be that nurse. You develop that trusting relationship. So when you provide information to that patient, they're thinking, you know what, this is a very reliable source. I know the information that she's giving me or he's giving me is going to be helping me as I take care of my disease process. Okay? Communicate very, very clearly, meaning don't use a lot of medical terms. You need to use layman's terms when you're communicating with them. Just like we talked about stinky a while ago. Those kind of terms, that's what you need to use because these patients don't understand. How many times have you heard a doctor talk to a patient? And where do they talk to that patient? Way over the head. And 9 times out of 10, as soon as the patient leaves or the doctor leaves and the nurse comes in, the patient looks at me and says, I don't have a clue what he just told me. So a lot of times what I try to do when I've got my patients I'm taking care of is when I see that doctor goes in there, I go right with him. And I listen to what that doctor had to say to that patient. So when he leaves, I can hear what he said, and I can reiterate, and I can say, look, this is what he's talking about. And I know exactly what he's saying. With also is if you are there and you've already developed this trusting relationship with this patient, they may look to you like, I'm not getting it. You know, the eye contact with them, I'm not understanding. You may be able to step in and say, you know, Dr. Jones, could you explain that to her one more time? You know, she's not getting, I mean, I'm not going to say, you know what, she ain't getting it. You know, come on. You know, you need to explain this. Or I may step in and say, you know what, Chelsea, are you really understanding what Dr. Jones is telling you? Is there any questions before he leaves that you need clarified? Because right now is the time, and we want to make sure that you understand everything that you need to know. Okay? So you're there again being an advocate for her or that patient because they're afraid, and I don't know why, they're afraid of doctors sometimes. They're afraid to ask questions because that doctor comes in, hey, how you doing? Stethoscope on, you got any questions? No, and they walk out the door. Who's in there with them all the time? Nobody. We are. We're in there with them. We've developed that relationship. They've got that trusting relationship, and they can say, you know what, that Dr. Jones, he never explains things to me like I want to. And you know what, if he's left the floor, and that's what my patient has told me, what do you think I'm going to do? I'm paging him. You know what, Dr. Jones, your patient in 314, Miss Henry, she didn't understand a word you were talking about. You need to come back up here and explain it to her. Okay? And you know what? They'll start taking time with their patient. I'll tell you one thing, I will have to say this about Whitley's daddy. That's one thing I've heard about Whitley's daddy. Do you care if I tell you your daughter? Out of all the things I've heard about your daddy, that's one of the biggest things that I hear. He is so good with teaching his patients. He spends time with them. You know, he makes sure that they understand what's going on. He's few and far between.
But he doesn't teach family.
But he doesn't teach family. No, he expects you to know. But you know, you see what I'm saying? There are doctors out there that will do that. They're not all bad. I mean, I love doctors. But in my next life, I'm going to marry one. He's an orthopedic doctor in Northeast, at Lake Norman, and I always said when I get married again or in my next life, that's who I'm going to marry. Well, he is so good looking. But anyway, they're not all not wanting to educate their patients. It's just sometimes they don't have time, and they depend a lot on us. So when you develop that relationship with the physician, you can call him and say, you know what? I don't think that they really understood what they're saying. And you can even talk to them on the phone. This is what I'm going to go tell the patient. I just want to make sure that what I'm telling them is exactly what you want them to know. For instance, like a dressing change. He's going to give the patient, he may go in and tell them, you need to change this dressing 3 times a day, you need to have this kind of curl-X, you need to have this kind of thing, and this, that, the other, and the patient's like, woo! So So when I call a physician, I may say to him, you know what, I need to go in there and I need to make sure that I'm telling them exactly how you want them to change their dressings. So he'll write down everything, and then I'll be able to go in and tell him exactly what the doctor wants.
I just have a question about the teaching. Is it only like you give detailed teaching depending on the severity of the thing? And the only reason I ask that is when we had our first daughter, of course, they had a lactation consultant come in and teach how to breastfeed and do all this. Got a lot of teaching at times. Then my wife, she got stung by something, almost had anaphylactic shock, went to the ER, and the only thing they did give to her was a printout of what she needed to do when she got home, and that was it. So is it depending on the severity of what's going on? Or is it just depend on the facility, or is it depend on the
Well, it depends on several different things. Yeah, the severity of something may be. I can see, I gotta watch what I'm saying here. Yeah, the severity of it has some degree of it, but there are sometimes they'll go and say, here's a teaching thing, here you go. I never do that as a nurse. I don't care how severe, if it's a bee sting or if it's still having a heart attack. At that point, I got to make sure that I'm teaching my patient exactly everything that they need to know. Now, I will say that from having a baby, there is a lot more information to give out for the patient to absorb than it is from a bee sting. Because if it's a bee sting, then we know it's very precise, and these are the several things that we need to do to make sure if this ever happens again, this is what you need to do. Do you see what I'm saying? No?
Yeah, I mean,
Having a baby and a bee sting is not that much information to give them, and lots of information to give them.
and the only reason I asked that is because they didn't even ask her, well, do you have a EpiPen at home? Is there any way that we can get you one? They didn't do any of that. And it's just like, here you go.
And that's bad. That is not. As a nurse, if I'm taking care of a patient, I will make sure, I don't care if it's a bee sting to having a baby, I will make sure that everything is hit with that patient. Discharge instructions, verification, learning, because I'm going to ask every patient when they come into the hospital, what's your educational background? Tell me what you know about this. I'm going to teach every patient. Now, the amount of information that I give them may vary, but I can't sit up here and knock wherever she went. You know what I'm saying? I want you to be a better person and a better nurse to make sure that your patient gets all the information that they need, that they fully understand. Does that make sense? In other words, do as I say, don't do as you see happening all over the hospital. Yeah. And that's what happens. Sometimes that's what happens with CNAs when they come into the program. They think, well, I see this nurse do this all the time. Well, it ain't right. Don't do it. But she does it all the time. Yeah, I've got to teach you the right way. And I want to make sure, I can't stress to you enough about how important teaching is. They deserve this. They deserve this information. They deserve to know where to go get an EpiPen. They deserve that information. I think we've talked all about that. I repeat myself a lot, don't I?
Repetition is good.
All right, we've talked about, I'm flipping right through it because I've said everything that is on this thing. As y'all can tell, I don't have notes. I just teach. I mean, I just talk. Huh?
Looking at your big old...
Oh, that's my little one. All right, we've talked a lot about transcultural teaching, but I did feel like that it had a lot more information in our book last year that I felt like I needed to address. You know, we were talking about having things printed out for our patient i.e. drug information or discharge instructions, make sure that that patient can read English. Speaking English and reading it is two different things. If they cannot read it, we have, or the hospitals and everything has pamphlets in different languages. Now, it may not be right there readily available, but you can ask someone on the floor and we can get it in another language. So don't give them something in English if they can't read English. Or they can't read at all. Exactly. Don't give me 25 handouts if I can't read. Okay? I think we've talked a lot about this so far. I think one of the biggest things that I see happening in a teaching setting is that we don't give the patients an opportunity to absorb the information. You know, we go right in here and we're giving them all this information at one time, and it takes them a while, and then we look at them and say, you got any questions? Well, I haven't processed whatever you gave me just a minute ago to even know what to ask you. So at that point, what I usually do is say, well, you know what, if I have something that they could read or whatever, I may leave that information with them, and I'll say, you know what, I'm going to give you a couple minutes to start digesting and processing all this information that you've been given. I'm going to come back in an hour or so, and maybe if you have questions at that time, I can answer them for you. Another thing is I always tell patients, go get them a piece of paper and a pencil and say, as you're staying here during your stay at the hospital and you're like brushing your hair, standing up brushing your hair, and you think of something, go write it down. Write that question down. So when we come back in, you can say, you know what, I've got 4 questions that I thought about a while ago. Can you answer these questions for me now? Yeah. Tell them the same thing as if they're at home. After they've been discharged and they realize that, I just can't really remember if she told me if I should change the dressing in the morning or the afternoon. What's going to happen when that patient gets at home and she starts thinking about that? She's going to get worried, and she's going to be stressing out, just like y'all, right? Something's not, the grades are not up or whatever. I'm at home stressing. And what do I usually tell y'all? Call me or email me, right? Tell the patient the same thing. Call the unit. Ask to speak to a nurse. If it's going to be something that you're going to be worried about, then please just call somebody. Don't worry about it all night long. Like one of the resources they have down at Northeast is that Ask First. Maybe they still have it. If the patient goes home and they have questions, give them that number and say, when you're at home, there's a nurse that answers that thing. She can answer it. If she doesn't know the answer, she can find the answer and get her number and call her back. Okay? Give them reassuring. Let them know that there are resources out there if they just utilize them. Okay. Oh, Jesus. What is happening? Did y'all do that? Somebody did that to me last year. Did something. What did I just do? It's like you restarted it. Oh. All right. One of the things that a lot of people want to use is humor when they're teaching. I try to use humor a lot. Sometimes y'all don't get my humor, but sometimes I do. But you've got to really watch your humor in a professional setting. There may be something that you say that may be offended someone. So until you have developed a very good relationship, trusting relationship with that patient, please do not use any type of slang words or humor until you have developed. Most of the patients, what they'll do, once you develop that relationship, they'll start cutting up with you a little bit. Okay? I'm all for cutting up. And I'm all for, but I'm professional about it. Okay? If they want to, cut up a little bit, laugh, and say something. But remember, you have to be professional. And you have to let the patient be the one that starts the humor. Because what I think is funny, someone may not think it's funny at all. Okay, so use that very, very cautiously. Is this thing like doing this? I will say, another thing you need to think about when you're talking to patients is make sure that you talk slowly and make sure that, because I talk very, very fast, and I've had patients look at me like, what in the heck did you just say? And I'll say, I'm sorry, I'm from the South. And I've got that slang, talking, and I'll say stuff, and they're like, slow down a minute. You're talking too fast, so slow down. So make sure that you do give them actual, or slow down a little bit, and don't run through it like I'm running through it. Don't use slang words. Just like we were talking about with the parent of the girl that my daughter was dealing with, just because they nod and they make eye contact doesn't mean that they understand. Okay? Does not mean that. A lot of times in different cultures, that is what they do. They nod. Yeah. And they don't understand what you're doing. So don't take that as they understand exactly what's going on. I think me and Jeff were talking about this. As far as when you're teaching a patient of a different gender, and you have to talk to them or teach them about their body parts, it is really beneficiary to you and the patient is if you bring someone of the same gender. Let me just give you an example. When you guys go to labor and delivery, my males, it's going to be really uncomfortable for you. Just going to tell you up front. So you will never actually be going looking in a female's bottom without having another female with you. First of all, to make you feel less uncomfortable, but to make them less uncomfortable as well. Okay? So if you're in a situation, it's sorry that we are in this situation, but we are, because of society. Used to, I could take care of any man and not worry about it, not have a thing going on, anybody thinking anything is going on, but now it's different. We had a student, I was telling Jeff this, we had a student in the PN program a couple years ago, had a female patient, and he was checking her femoral pulses. Well, of course, he was having a little difficulty. She took it as a wrong thought that the guy was trying to fondle her. That was not the case. The student was generally trying to find a femoral pulse. So if you're going to have to be in that situation, please take someone, you guys take a female with you. If the girls are in a situation like that, you may need to take a male with you. Okay? Sorry that it's come to that, but that's the kind of things that's happening. We've also talked about including family in their planning and teaching. I think one of the biggest things that is hard to do when you're in the hospital when it comes to teaching is find the appropriate time to make sure that the teaching is going on, because we're such a scheduled person sometimes. You may have it all planned out, and then you go in and your patient's going down for a CT scan. So don't get frustrated if you're not able to carry out every bit of the teaching at one time. You may have to teach a little bit here and a little bit after they get back from their CT scan. But it also gives that patient a chance to digest the information that you gave them earlier. and it encourages them to answer more. You can answer more questions for them. Okay, evaluating. I know Miss Ward talked to you about documentation. If it wasn't done or documented, it wasn't done. Has she told you that? Okay. Well, it's the same thing with our learning, and the same thing is how we need to evaluate it. Now, I've got evaluate up here, but you're really not, until we go over the nursing process, evaluation is going to make more sense to you when we go through the nursing process, because evaluation is one of the steps that we do during the nursing process. So as I'm looking at my teaching, I need to validate and evaluate, was that actually learned? Okay, and that's how we evaluate it. I want to see if there's ways that I can make sure that they got the information. For example, I went in and taught them how to give an injection. A way I can evaluate if they got that information is a return demonstration. If they return the demonstration that they drew up the medication correctly and that they injected it correctly, that is my value. That's how I evaluate it. That's my validation of making sure that they got the information. So when you document, you got a question?
No.
Okay. When you document that, you have to give some proof that you did it and what they did that made you evaluate and validate that they learned. Does that make sense? You can't just go in there and say, I gave the patient diabetic teaching. They learned. I got to say how they learned. They returned the demonstration of drawing up the medication. They returned the demonstration of injecting the medication. You see what I'm saying? I've got to, or they were able to verbalize back to me the 3 signs of hypoglycemia. Okay? They were able to verbalize. That is a way that I can make sure that their teaching has been done, or is there more teaching that needs to be done. Okay? The majority of the things now is a checkoff sheet. And so if it has any teaching that you did, you can go right in that what you taught or check what you taught, but it's going to tell you how did you, or ask you how did you evaluate it. At that point, you've got to put return demonstration or verbalized back to me. Okay, does that make sense? It's not just you're not gonna have just a little check mark and say, yeah, I taught them about the signs of hypoglycemia. You got to tell how you know that patient received that information and that they learned that information. I just went through the domains there. I think I've been all that. Documentation, that's exactly what I was talking about. The other thing that's used for is when the patient gets ready to go home and we're looking at the discharge instructions and looking at the discharge teaching. And let's say that Pat taught the patient yesterday the signs and symptoms of hypo and hyperglycemia. And Kim, yesterday afternoon, she taught the patient about how to give injections. But they didn't document anything that they did it. So when I go in and I'm getting ready to take my patient to go home, I'm going to have to go through all of that information again because they didn't document it. Now, let's say they did document it. So out of the checklist that I've got of things I've got to go over it, I'm going in right before that patient goes home. And I'm going to say, oh good, Pat taught them this. I'm also going to say, now I know another nurse taught you this. Do you have any questions about that? Did you understand just making sure that I've got that information, that they didn't have any more questions, and they've got that information. Okay? So it's wonderful for the patient. If she's got 15 things that have to be taught to her, it is nice for one nurse to come and teach her a little bit of information at one time, and then somebody else come in. And so at the end, all that's checked off, and then the nurse that's actually helping her out the door can reiterate with that and go over that and say, you got any questions about this? You got any questions about this? I see where this person was taught there. So it's another opportunity to have the patient to ask more questions and to validate and evaluate, did they get the information that they needed? Okay? So this is a big, big part of nursing, teaching this. So when you have your plan of care that we're getting ready to go over in a couple days, teaching is going to be a vital part of that plan of care. I've got to make sure. Now, have you had an opportunity to look at, you did a pathophysiology, right? Did it say anything about interventions that you would do for your patient on the pathophysiology sheet? Something about, did you ever see anything that says teach the patient this? Oh my gracious, alive. So the book agrees that teaching is a part of what's going on. So you're not just going to have to make up out of your brain what you need to teach the patient. You're going to have a resource that's going to tell you these are the things that you need to make sure that this patient knows before they go home. Every patient that comes into the hospital is going to have some type of knowledge deficit as a nursing diagnosis. And we're going to talk more about a nursing diagnosis. They're going to have it because they don't know what's going on with their body. And they are seeking out questions. Why do you think they came to the hospital? They're seeking out questions to figure out what the heck's wrong. It is our responsibility to make sure that they get that information. Okay? Any questions about teaching? What are you scared of besides, or nervous about, except not knowing the answer to the questions when it comes to teaching?
Just making sure it's in a logical flow. Right. I find that when I'm giving instructions, I tend to jump around a lot, and it's hard for me to make it smooth and smooth it out. So.
Exactly. But is that something that's going to come just like that?
No.
It's going to be a trial and error thing. It's okay if you don't have it in a logical way at the beginning. We'll learn. We'll fix it. Okay? We'll fix it for you. Anything else that y'all are afraid of when it comes to teaching?
Say you're a nurse and you're teaching in the hospital. Do certain hospitals have areas where you can go and search for documents you need, or is that something that you're supposed to come up with on yourself?
They do have documents, especially like on medications and some on disease processes. They do. But like I said, I'm okay with you went and researched something and found a good article or found something that was very positive for someone, as long as you bring it in, okay? Yeah. But because teaching is such a vital part of nursing, they want you to use the resources they have, and they'll have a printout to make sure that we're not missing what the patient needs. But I don't have a problem you bring other things in, but we've got to make sure that we follow their database and follow what they will do to teach. And there may be times, like I said, you're not going to know exactly what needs to be taught. That's when you go to me, or you go to one of the nurses and say, I'm not sure about this. Can somebody help me figure out what exactly I need? The biggest thing in teaching is you've got to make sure that the patient's getting the right information and that everybody's telling them the same thing. Because just like with y'all, y'all are going to say this. Every class says this. Miss Walker's a different instructor than Miss Cherry. Miss Walker's a different. Maybe I'll do it. I told y'all I was not good with this. All right. As far as communication, I know how to communicate, Miss Walker. What are you talking about? Well, communication is a major skill in nursing. Probably the biggest thing that you don't think that you're going to have to study and worry about communication is, or worry about things you're thinking about communication. There is a way to communicate with people. If you heard what I said to her a while ago when she said, I can't remember exactly what she asked me, and I said my return response was, tell me about something. And what I said to you, when you said, how am I going to handle a patient? I said, you would say, tell me how you feel. Tell me. What do I want to do when I want to communicate with a client? What is the whole goal of the communication? Let me just back up. Maybe I got a little ahead of myself. What is the goal of communication? To gather information. To gather in the information to do what? To provide care for that patient. The more information that I have, the better I'm going to be able to plan my care, right? So I've got to learn how to get as much information out of a patient as I can to make sure they provide adequate care. So my communication is a critical skill as a nurse. I've got to, in every aspect of it, it is important. In other way, I mean, first of all, in assessment. When you were doing your assessment of your partner, didn't you have to communicate with them? Mm-hmm. Had to communicate. When I'm teaching them, don't I have to communicate with them? Mm-hmm. When I'm providing care for them, don't I have to communicate with them? Mm-hmm. So everything that we do revolves around this communication skills. And there is an effective way to communicate with someone and an ineffective way. So what I want to teach you how to do is to effectively communicate with your client, okay, or with your patient. One of the first things that you've got to do is identify yourself and start developing a trusting relationship with them. Okay? You've got to start developing them that they trust you, that you just let them know that you care. You don't go in there and start throwing out all this information that you want to teach them before you have actually identified yourself, told them the purpose that you're there. Develop a friendship. It's the same thing that you do every day when you meet someone new. You have to first develop that friendship and that relationship. Because if they start building that relationship with me, then they're going to be more apt to tell me more information from my assessment. And then when they tell me more information from my assessment, I then can start planning my care for them. Because I'm going to have so much information from my assessment data that I'm going to be able to plan my care. Now, a lot of this stuff, the interventions and the outcomes and evaluations and that kind of stuff doesn't make a lot of sense to you right now because we haven't gotten into the nursing process. But when you know what assessment means, and you know that's the first step of the nursing process. So as we go through the nursing process, you'll learn that you'll set goals for your patient and you'll develop interventions for your patient. So when you're hearing interventions, what do you think interventions is? Things that you're going to do. you're gonna do for your patient. Can you give me an example of what an intervention would be? Okay, apply oxygen, right, at 2 liters per nasal cannula. Okay. Give medication, exactly. I want to administer lisinopril, 20 milligrams, PO, PID. Huh? Assess or monitor vital signs. What did we just talk about? Teach them to turn, cough, and deep breathe. See, you're sitting here thinking of interventions, and you hadn't even had the nursing process, which is very, very good. Very, very good. But anyway, we're going to build on this, I promise. But right now, we're just talking about communication. There are 2 types of communication. You guys know this, verbal and nonverbal. Verbal is what we say, or whatever is spoken. But what gives more information than verbal? Nonverbal. Nonverbal communication can tell you so much about a person. Like for me, I haven't rolled my eyes at y'all yet. But that's one of the nonverbal communication skills that I'm so do all the time. And I know I shouldn't, but I do it. So on your evaluation at the end of the semester, don't need to write, Miss Walker rolls her eyes, because I've always had that on my evaluation and I'm not going to change. Alright? So I roll my eyes. That is a nonverbal communication. Can't help it. I tried. But anyway, nonverbal is so much more than what it tells the patient. If I walk into a patient room, one is a nonverbal communication skill that I have to do with that patient. Smile. Or
Eye contact.
Eye contact. Exactly. How many times do you hate when you go in and have a conversation with somebody and they don't look at you? Drives me to drink. How many nurses, this is what gets me, some of these nurses come walking into the room, this is what they do. Hey, Mr. I, how you doing today? I need to ask you a couple of questions. Can you tell me when you were here last or why you're here? Drives me bananas. Okay? I did not respect her in any way. And we are going to respect our patients. The first thing I need to do is I need to come in and I need to say, hey, Mr. I, my name's Leanne Walker. I'm a nursing instructor from Roy and Cabarrus Community College. How are you today? I looked at her and identified who I was. And that's exactly what you got to do. I always, I don't know if it's because I'm a nurse or it's because my daddy, when we were growing up, if we got scolded, we had to maintain eye contact with him. If we looked away, my daddy hit me one time when I was growing up. And I looked away from him when he was scolding me, and he knocked me clear off a stool. Because I did not maintain eye contact with him. So I don't know if that's why I have a hard time with that. If it's because I'm a So, my daddy really did. One time in my life. So, anyway. I just think that shows a major respect for someone. That you are actually listening to someone and you're looking at them. That is so important. So, please, when you identify yourself, maintain eye contact with someone.
Another thing also with eye contact, it seems, because I also taught in elementary and middle school, but is if you don't make sure, even like the students look at you, you're not sure if they're even getting or hearing, like correcting a small little one that's like doing things, and you tell them what they're doing wrong, and do they understand, and they're looking around, and you say, no, you need to look at me. I want to make sure you understand while we're talking what's going on. So that lets you know that they're with you, and so it's important for.
Now, there are going to be patients that will not maintain eye contact with you. Okay? And that is, there's nothing we can do about it. Now, there's a lot of times like don't look at me. Don't look at me. You know, if a patient's like looking down, sometimes I'll go. Just to see if they're just like, and if they're not wanting to make eye contact with me, if I go down like this, they will immediately turn. They will turn away from me. And at that point, I need to realize that they're having a lot of communication issues and a lot of self-esteem. I mean, there's lots of things going on, and I got to figure out, I'm not going to make them feel uncomfortable by making them look at me. And it could be a culture thing. I will still look at them and maintain me looking at them, whether they're looking at me. And eventually, sometimes they'll come around and maintain that eye contact as well. But I think that is so important. The introduction of yourself is so important. Handshaking. You know, I don't care if it's male or female to female, male, whatever. Handshaking is a nice gesture for someone. Now, do I need to teach y'all how to shake somebody's hand? Y'all know how to shake somebody's hand?
People need to learn.
Firm handshake. Firm handshake. Firm. That's another thing my dad taught me. You never shake anybody's hand when they're like there was a dish rash. You've got to be firm. Y'all hear a lot about my dad. He passed away 3 years ago, so he's a lot of the actual case that we're going to be doing for the nursing process is my dad. So we'll do that. But anyway, all right. So where was that? Yeah, gestures. Make sure eye contact. Now, when you walk into the patient's room, you need to develop a relationship, or to, you know, they start communicating back with you before you sit down and get on the same level with them. Okay, because it may not be a good time. We don't sit in our patients' beds. Okay, so don't sit. Although when you see me go to the hospital, what I do, go with my patient. Y'all will not like do as I say, don't do as I do. One of those things I'm so bad about, because most of the time the student is sitting in a chair and the patient is in the bed, and I just go flop right on the bed with them. So I know I shouldn't do that, but I do. But anyway, once you develop that, get on their same level, because you know how sometimes it feels when somebody's over and over again communicating with you. You're not going to feel comfortable at that point. So if you're going to sit and teach and talk to them and do an assessment with them, get on the same level with them, so you make sure that you are letting them know that you are communicating with them appropriately. Touch is another thing that is a nonverbal communication skill. I'm a huggy, touchy kind of person. If y'all haven't realized that yet. But when you go in and communicate with your patient, you have to not go straight in and just hug them and love on them and that kind of stuff. You need to, you know, the handshake is the first touch. Then later you may just a touch on their hand or a touch on their shoulder, you know, and that sort of gives, you know, people will let you know if it makes them feel uncomfortable. Like I have a nephew that I hug all the time, and he's like, you know, that makes him feel uncomfortable. You know, and I'm over here going, oh, why see you? Love all over him. You know, and it makes him feel uncomfortable. But your patients will know and give you that cue to let you know, don't touch me. You know, do not touch me. No kissing. We had a patient I guess it was last year, and he grew up down the street from me, so he saw me when I was wee teeny, running around everywhere, and he was dying, and I hugged him one day and kissed him on the cheek, because I used to kiss him on the cheek all the time as a kid. Well, my student came out, she said, Miss Walker, you just kissed that patient. And I was like, oh my gosh, I did. And I didn't even realize it, because I knew, don't do that. Don't do it. I said, here, I did not mean to do that. But he was a friend of ours, and I just kissed him right on the cheek. But anyway, no kissing. All right. We also talked about age groups with communication, with words to use. There again, you're going to ask that patient's parents or significant other, tell me some terms that they use to communicate, okay, when it's age appropriate. I need to know what terms that they use at home to know that they will know what I'm talking about. education role, we talked about that too. When we're communicating, remember pace is something that you really need to make sure that you're aware of. Don't give them too much information at one time. It's almost like y'all. Ms. Walker, I've had enough of the information you're giving me. Right this moment, you need to stop. Okay? They're like that too. Make the pace very, very smooth and slow and put the most important things up in the front. Simple is always better for all patients. They seem to do better with the simple, and as they start the simpleness, it goes better as you get more complex. We've talked about timing. We've got to make sure that when we're communicating with patients that it is very client-oriented. Okay? Client-oriented, and be very sensitive to their needs. Not saying that you can't carry on a conversation with someone, but there's a lot of times there's vital information that has to be gotten when you're doing your assessment and when you're communicating with them. I'm not saying don't go in there and just say, hey, my name is this, and say I'm doing a head-to-toe assessment on it. You start doing your head-to-toe assessment. Build that relationship at first, then get to the point, okay, while you're there. Adaptability, I think that's probably one of the hardest things that students have a hard time with, being able to adapt to different situations, because you're going to go home on Monday night and you're going to have your whole plan of how you're going to talk to this patient and what you're going to say and have it all out, and then when you go in there, the patient's asleep. Excuse me, you need to wake up because I need to communicate with you. So then it stresses you out because you've gotten out of your little routine, right? So you have to be adaptable to the situations to know that maybe I can't get everything done right at one time. Okay? All right, this little poop thing's messing up again. What is it doing? Am I timing out or something? Do I time out? Time out! Everybody get a time out. Does anybody else have problems with this? All right. Credible. We talked a lot about this as far as teaching with someone. What do I really mean about being credible? What does that mean? Reliable, honest, and honest is a big thing about me. Don't give me no BS. Be honest with me. Ms. Walker, I don't know that. Tell me the truth. And you need to tell the truth to the patients. You know, sometimes if they ask you a question, you need to be very honest with them. Let them know that this is the way it is. Don't want to sugarcoat anything. And like I said a while ago, if you don't know something, tell them, I don't know. And as you have building that relationship with them, they're going to trust you, and especially if you tell them you don't know something, you go find the answer and you come back with the answer. What has that happened? What's just happened? Credibility. Credibility is developed right then, and they're going to know that you're credible. If you say you're going to do something, do it.
Maybe in our readiness or some point when we started school, somebody said one of the students had a patient who asked them, are they going to die? And so, like, how would we even handle that at all if for our patients to ask us that?
So how would you handle that? Right. Yes.
But if you, seriously,
yeah,
are really wanted it, they working to do the same. I don't know.
I would probably turn it around. Well, tell me how happening here is I didn't have to answer her is she dying, because we're all dying. But I need to figure out, I'm picking up on her, out of her her comment, that she's got some concerns about dying. So I'm gonna turn it around and ask her, tell me how you feel about dying.
See, and one reason I mentioned that because today's the day that we lost our son in car accident. It's been like 11 years. And so when he was in the hospital in the ICU and you ask that, and of course it's a little more, they know it's so serious, but I mean, sometimes you really want to know that, or you want to be reassured that what can be done or what, so I know we're probably not really qualified because we're students and I just don't want to hurt anyone.
Right, but I think at some point in time they need to know. But I also will say something to the fact, well, you know what, I have no control of when that's going to happen. But according to your diagnosis and according to what's going on with your body right now, we've got to get your blood pressure up before
positive reinforcement.
Try to take it. We got to have this happen and this happen and this happen in order for you to get better. Or let's just focus on you getting better. Now, there are some nurses that, like, I wanted someone when my daddy was dying. I knew he was dying. I knew when I took him to the hospital, that was the last time I was going to take my dad to the hospital. And I was daddy's girl. I mean, at one side and down the other. But I went out to that nurse. I went out the door. I said, you look me straight in the eye, and you tell me if my daddy's dying. And she said, yeah. But I needed that. I'm not going to sugarcoat things, but I'm going to be honest with people. I'd have to look at everything that was going on with that patient. I'd say, well, these are the things that are going on right now. If we can get your kidneys to start working back, that would be those kind of things. You know what I'm saying? So I wish, like I said, I wish that I could give you a response to every situation. I do wish I could, but I can't. I mean, there's so many different things and so many different responses. And you know what? There may be times that you do say the wrong thing. I've said the wrong thing. I call
Learn from
exactly. I call everybody sweetie. I call everybody honey. Love it, and wrong thing to do, but I do it. I'm like, geez, I should have never said that, But as far as you've got to think when you're communicating with someone, you have to maintain honesty with them, develop that relationship, but you also don't lie. Don't lie. And if you don't know the answer to like if she would have said to me, am I dying? I would have said, you know what, I'm not sure what's going on right now, but let's talk to your doctor. Let's talk to your doctor and let's see what else is going on. But as you have assessed them, and you can see, you can start going through and seeing what's going on with them. But I can't, some people come out, especially family members come out and say, tell me the truth, like I did that nurse, tell me. I know my daddy's dying, I need somebody to tell me he's dying. And that, honey, as soon as she told me that, I was on the phone, I said, get me out of here, and we going home. Because he's going to die somewhere besides this hospital. But I needed somebody to tell me that. And communication is, some people say, oh my gosh, Ms. Walker's teaching me how to communicate. And I'm like, I am, but I'm not. I am, basically. I'm telling you what to say. All right? One thing that I will say, and I'll talk about these two types of things before, because I don't think I put them on my slide. I might have. But as you're learning how to, and I don't think your book talks too much about this, so this may be a time that you want to take some notes. There's two different types of questions that will help you in learning how to communicate. One of them is an open-ended question. Do you know what I mean when I talk about open-ended? Right. Not just a yes or no answer. Why is an open-ended question better than a closed-ended question. I can get more, because what is the goal of communication? To get information. So if I use an open-ended question, I can get more information out of the patient so I can do what?
Plan of care.
Get my plan of care. So it's like a circle. Okay? The more you give me, the more I'm going to run with it, and I'm going to be able to do all kinds of things, and I'm going to make you better. Okay? That's the way you got to look at it. I want the most information. I will tell you that NCLEX is going to have a lot of communication questions on there. You will have communication questions from now on out. And most of the time, when you look at a communication question, it is something that you will probably say to yourself, I would never say that. That would probably be the right answer. Okay? Let me tell you the story when I was in nursing. I mean, I got so many daggone stories. Y'all get tired of my stories. When I was in nursing school, I was in the psych ward at Charlotte. And I was not comfortable at all. Did I know how to communicate? Heck, fire no. Didn't know what to say to this crazy person. That's exactly what I thought when I was in nursing school. This is a crazy person that's following me around. It was a guy, and if I would go sit on the couch, he would come sit beside me. If I would move over, he'd move over. And it was like, I'd say, hey. He'd say, hey. I'd say, hey. It was like I couldn't get past the hey. I did not have a clue how to communicate with this person. I mean, I've been talking to people all my life. And why could I not talk to this guy? He was, first of all, making me very uncomfortable. You know, because at one point in time he said, when I get out, I'm going to come see you. I'm like, okay. So I felt at that point in time I needed help. So I went to my instructor and I said to her, I said, I'm having trouble communicating. And she said, you are? And what's wrong? And I said, well, this guy's making me feel uncomfortable. He's getting more close to me. I'm just like, I don't know what to say back to him. And she looked at me and she said, I hear your frustrations. What are you talking about? I need some help here. You're very frustrated. Yes, I am. She was being therapeutic to me. She was trying to get me to, and I'm like, what the heck? It's the same thing with these NCLEX questions. I would never have said that to anybody. I hear your frustrations. That's probably the kind of questions you're going to see on NCLEX. You know? And you're like, dang, that makes no daggum sense to me. Needless to say, she didn't help me one daggum bit with communication skills, hearing my frustrations. And I never communicated with that guy right. I mean, I was just like, and I told him one time, I said, no, you are not coming to see me. I had nothing else to say, but no, you are not. But anyway, I learned over the years how to communicate with someone, and it's very important for you to get them to give you the information. It's not about me right now, it's about them. And if they can give me a lot of information, then I can plan my care better. Now, closed-ended questions, is that always bad? No. But they sort of look at closed-ended questions as non-therapeutic. Therapeutic means that's good stuff. Non-therapeutic means it's not a good communication skill. I have a hard time with that sometimes, saying it's really non-therapeutic, because there's times that I have to say to somebody, do you have pain? Yes or no? Now, do I stop there? No. Then I can go next to a open-ended question. Tell me where your pain is. That's an open-ended question, and I'm going to get more information. But ideally, we want you to have open-ended questions so we can have a lot more information to help plan our care. But there are times that you're going to see them say that closed-ended questions are not therapeutic. And that's not always good. So what I want you to pick out, you're going to be having a statement that I would say to a patient that would give the most information. And it's going to be stuff like, tell me how you feel. Can you imagine saying that to somebody? You say that to somebody, tell me how you feel. You don't say that. How you feeling today? That's what you say usually. That's not going to be something you say in the clinical setting. You're going to say, tell me how you feel. Tell me about this. Okay? So you're going to turn your conversation around to make it seem like they're in control of the situation. Okay? That they're giving me more information that I can get to plan their care. So open-ended questions is the best, and it's the therapeutic, and it's going to sound like, give me some examples. Open-ended questions.
Describe your ideal vacation.
Huh?
Describe your ideal vacation.
Describe your ideal vacation. Did you find that somewhere else? Oh. Describe. You have somebody. Well, describe that to me. That's not. I mean, that's going to give me a lot of information. If you want to hear my vacation, I'll talk to you about 4 days on my vacation. Yeah, tell you what all I did. But with my Bubba cup. But you want information to give you a bunch of stuff. Tell me some more. Tell me how that made you feel. Exactly. That tell me works really, really good.
Tell me what I can do.
How do you feel about dying? Exactly. Tell me how you feel about dying. Or how do you feel about dying? How is a good term too. Because you can't answer how question yes or no. Is this a problem? Yes. So is a closed-ended question. Do you think you would have trouble finding an open-ended question and a closed-ended question? All right, we just about a couple more minutes. Any other questions about? Let me see where I am in my notes, and I'll see. Oh, I will tell you that I put up the process recording up on my unit, and I'm doing pretty good. All right, so talking to somebody, do I expect to see you do when you're talking? Eye contact. Eye contact. Y'all never forget the eye contact with you, because all you can picture is Miss Walker's daddy going, pop, knocking off the thing, going, yeah, she doesn't look at somebody. Exactly, eye contact. Get on their level. The other thing is you got to think about is your tone and your pace. If you know, I know y'all heard me talk. I talk very, very quickly. But when I sit down to teach a patient, I do not talk like this. I talk very slow, and not that I'm making them feel stupid. I have to get my pace to where I'm not overwhelming them with so much information at one time that they're not getting it. Okay? Give me some way. How do I assess or evaluate to know if my teaching has been? I went back to teaching again, didn't I?
If they can demonstrate what you're talking about.
It's like I can have them return the demonstration to me.
Or just repeat some information.
It repeat some. So do you feel pretty good about knowing how, when you teach somebody something, how to evaluate to see if you really met it? Good. I'm not going to go back on teaching. This is the way that ADD brain looks or works. Open-ended questions. Give me some examples of open-ended questions. We said that a couple of them a while ago.
Tell me how you're feeling.
How do you feel? Tell me how you feel.
Explain to me the symptoms you are experiencing.
Explain to me the symptoms you are experiencing. Describe. Awesome. Awesome. Closed-ended questions always bad. No. So when you ask a closed-ended question, you're probably going to follow it with an open-ended question. there's times that we need yes or no. Are you in pain? No. Or, okay, you tell me, ask me, am I in pain? Yes, I am in pain. Describe your pain to me. Exactly. So I ended with a yes or no, or got a yes or no, and then I went on to something else and got more information. So I think you're pretty good on that. Do I need to flip this? Did we talk about nonverbal communication the other day or no? No. Okay. Nonverbal communication is our body language. I think I said something to you the other day about, yeah, I roll my eyes to y'all. Okay? That is a nonverbal communication skill that I am not proud of. But I do it. I've been doing it for almost 50 years. So I know that's something that I may do to y'all that I really don't mean to, but I do. I just don't do it to my patient. That is something that, how do you feel or how would you feel if I rolled my eyes at you?
Stupid.
Do I want, yeah. Do I want to make my patient ever feel stupid? They sort of sometimes feel stupid enough when they're already in there and they're not sure what's going on and they have to be taught a lot of stuff. So I never want to make them. I would never roll my eyes at any patient. The gist of this nonverbal communication, it tells you so much more than verbal does a lot of times. I think I used the example the other day about the nurse coming in and she's getting ready to do her assessment. She walks in the door and she's like, okay, what's your name? Why are you here? Oh, yeah. Yeah, you got this going on. Yeah, okay. What is my nonverbal communication showing her? I'm not one bit interested in what's going on with her, am I? So make sure that you watch that nonverbal communication. It tells you so much more than you ever would realize. Forgot about that. Forgot about this little thing. Yeah, I'll just read all that. Personal appearance. We haven't really talked too much about personal appearance as far as communication, but that is something that is important. We're going to talk about when you go to the hospital, why is it important for you to be clean? Now, I know you're thinking, oh, Miss Walker, you know we all take showers. I had a student several years ago that had BO. And I had to tell that student that she had BO. It was probably one of the hardest things I've ever done. When you come to the hospital setting, make sure you're clean. Make sure you've got deodorant on. Now, I don't want a lot of, are y'all smelling? Do I stink? I don't want to have to tell somebody that they have BO. One of the major things that we had a problem with 2 years ago was the student smelling like smoke. Okay? When you go to clinical, you cannot smoke on the way in your car, on the way to clinical. I'm not telling you when you smoke when you can't, but I am telling you. Unless you get out and clean yourself up, because I had a patient, she said, this student smelled just like smoke. Think about how you feel, and I'm not knocking you smokers. I was a smoker when I was a high schooler. My daddy smoked for 52 years. I'm not knocking it. I'm just saying to you, make sure that you get that smell off of you. And I know, like, if you have your bags in your car and you smoke in your car, then that smell is going to stay on that bag, and it's going to stay on your stethoscope, it's going to stay on your lab coat. That is not acceptable. Okay? That is part of our policy, but I just want to throw that out at you to let you know that personal appearance is important, and that is part of it. You want to have someone that is professional looking. Clothes are ironed, hair's out of your face. That's all part, because nobody's going to trust you. You come flying in there, your hair's every which way, and you smell like smoke, and you're not going to want to develop a relationship, where somebody caring for them. So make sure that you're good and clean. The other thing is you want to think about is your posture and gait. If you go walking in there going, here I go, gotta go teach Miss Jones again, she's going to pitch up on it. It's not going to make her feel like she is worthy of getting our instructions. So watch your posture, watch your gait, make sure that you're holding yourself up good to go in and positively take care of your patient. Gestures. As you can see, people say I couldn't talk if I didn't have my hands. Okay, so people threaten to tie my hands behind my back, and then that's the only way they can get me to shut up. But I know patients are in our communication, we do use gestures, and that's okay. The only thing, don't go flip them off, you know what I'm saying? But, you can point, you can do this kind of stuff, but make sure you don't use any obscene gestures. And I know that sounds sort of elementary, but I just want to make sure that y'all knew that. Communication, obviously we know about email and that kind of stuff as far as communication, and we know that is an advantage and disadvantages of it. The biggest thing that we worry about when we do that SIM chart is HIPAA. Do you know what HIPAA is? I'm sure everybody knows what HIPAA is. In other words, you can't talk about anything about your patient. So when you document stuff on that SIM chart, we have to know without a shadow of a doubt it's going to us only, and that no one's able to get into that program so they can get information from their about their patient. Another thing I want to say is when you go to the hospital and you get onto the elevator, you are not to say anything about your patient, especially if there's somebody else in the elevator with you. Patient confidentiality, because you never know. Deanna could be in there and Ashley comes in there and Deanna's going, I had this patient and he was in a car wreck and his wife was doing drinking real heavily and he beat the mess out of her, and she could not say his name, but the story that she's telling could be someone in their family in that elevator. Okay? So your communication at the hospital, you are not to talk about patients in those settings. Okay? Because you never know who's around, and that's breaking HIPAA. All right. Okay, we've talked about factors that influence communication. We've talked about things that the developmental processes, like playing with children. Have you ever seen, let's say a child comes in and they broke their arm. A lot of things that they use to help teach that person or communicate with that child is they'll have a stuffed animal. And they may actually put a cast on that stuffed animal, because that's not only helping teaching, that is helping communication as well. So the developmental stages, we've got to use whatever's appropriate for their age group. This sort of, I think about my husband every time I think about communication sometimes, because I'll communicate with him and I'm meaning one thing and he'll look at me and take it another way, and he'll say, honey, I'm thinking with my left side of the brain, you're thinking with your right. And the left and the right are not getting along right now. So, and that's true. So sometimes, not saying that one gender is smarter than the other gender, is sometimes when you're communicating with the opposite sex, they may not understand, because males do think with the left side of their brains, and females think with the right side of their brains. Okay, so the communication, you've got to make sure that they understand what you're saying when it comes to different groups that you're communicating with. I know a lot of my male patients, they want to be very independent. Not that our female patients don't, but we see that more in male patients. So when you're communicating with a male patient, give them some independence. Okay? Female patients have a tendency to say, make sure I'm doing this right. They need confirmation. Where males think, I know exactly what I'm doing. Females say, tell me I'm doing it okay. Okay, and that's just the way we are. Personal space. I think we talked a little bit about this the other day, but I'm not sure. I do not want you to memorize what the different feet is, because when you say a foot to me, I'm thinking, okay, it's about this far. I'm not good with, my husband says, drive 2 miles down the road. I'm like, 2 miles? How do I know when I'm going 2 miles? I'm just not good with that kind of stuff unless I have a ruler, like a wound or something I measure, and I'm just not good. So I don't want you to memorize the different personal spaces, but I want you just to have an idea of what, if you're getting in someone's space, when you first come into someone's, you need to stay away from them until you have not stay away. But don't go right up on them when you're first developing your relationship with them and your relationship with them. You want to stay back. Then as the relationship becomes closer, they've developed trust in you. You can come closer at that point, and you can even touch. Who saw Dirty Dancing? Everybody saw Dirty Dancing. When Patrick says, this is my space, and this is your space, as they're dancing. Think about that. There's a lot of people that don't like you to come into their space. Whereas me, I go right to somebody, hug them, tell them I love them. Not my patients, but people I meet in the society and stuff. I'm a very touchy-huggy kind of person. But I have to watch that in the hospital because I can't just go hugging and kissing all over my patients. And I can't invade their space. So think about Patrick. I love him. Think about him saying, this is my space and this is your space. And don't go in and invade that space until you have developed a relationship with someone. So you remember Dirty Dancing, Patrick says, this is your space, this is my space. Alright. Now, let's go. This is probably the biggest thing that we're going to learn about therapeutic communication. If you go to page, if you've got your book, if you don't have your book, that's okay. Page 472. You know what I mean when I say therapeutic communication? Does that make any sense? You know what I mean when I say therapeutic? Helpful. Trying to help someone, because my job as a nurse and my patient, we've got to have a team effect on this. If the communication is going to be therapeutic, then we both have to have a relationship, but our relationship is very goal-oriented. So if I have a therapeutic relationship with a patient, we both have goals that we've got to meet. It's very, very goal-oriented. So in other words, give me an example of what would be therapeutic when I go into my patient's room to communicate with them.
How about instead of saying that you will get through it, say like we will. And I'm like, as if you're working with the person. You understand what I'm saying there?
No, I'm not sure if I'm getting what you're saying.
If someone's like,
if the doctor says the person needs to lose some weight to do it, instead of saying, you will get there, so we'll get there together, we'll find a way. You know, making it seem like you're working with them instead of them on their own. That makes some sense.
I can understand where you're saying, as a nurse and a patient, I'm going to give you ideas to help you
Yeah.
get in that get that goal met.
Yeah.
But I don't know that I would say, me and you's going to do it, girl, you know.
Yeah, I know I meant as the way, you know, I'm going to help you, I'm going to give you the tools, I'm going to be there.
Exactly.
I'm going to answer
gonna work
questions.
together.
Exactly. We're
Thank
going to
you.
work together.
That's what I mean.
But it's got to be a goal-oriented thing. I've got to have her ready and me ready to give her, she has to be ready to accept the responsibilities of the changes that may need to make, and I'm going to help her do that. So I guess I can see it that way. It is very, I mean, it's almost like when you first decided that you were going to go into nursing school. Okay? Your goal is to get into nursing school. Well, you've met that goal. My patient's also the same way. There's going to be goals that I need to make sure that my patient meets. And we'll talk more and more and more about this when we go to the nursing process as far as goals that were met. But as far as therapeutic communication, there's techniques that we have to use to make sure that our communication is helping us meet the goal we have set for our patient. Does that make sense? No?
Repeat that again.
I can remember what I said.
Communication is helping them with their goals.
Therapeutic communication is so focused on making sure that the goal is set that I have to make sure that I communicate with them everything that I can to get as much information out of them to help me meet the goal that we have set together and get that goal accomplished. Does that make sense? So I want to get more information out of them. When you look at this page, if you haven't, there are several therapeutic communication techniques that are listed on this page. Now, when you begin to communicate, and this is where we'll talk about the process recording just a little bit, when you start communicating with someone, the biggest thing that you have, that you fear, is not knowing what to say. And if you look at the first therapeutic communication that is in your book on page 472, what is that first? Using what? Silence. Would anybody think that silence is a therapeutic communication skill? Would you think, if you're looking at it, would you think of it being therapeutic? Right, because there's a lot of times that you just need to be there for that patient. You don't need to be judgmental. You don't need to give them advice. You just need to sit there with them. That is very difficult for sometimes us to think that that can be therapeutic for someone. Example, my dad's died. I don't need somebody to sit there and say, oh, he's going to be better. Oh, he's going to be in heaven with Jesus. I know that, but that's not what I want to hear right now. I want somebody just to sit there with me, let me cry, let me get my feelings, my emotions out, and I just want someone to sit there. And if you're never sure of what to say to somebody, use silence. Yes. I walked in first thing this morning, and one of our instructors is in there just a-bawling. Just a-bawling. She's got a lot of family, or her aunts were real sick. And what did I do to her?
Listen.
I didn't say a word. I walked right over to her because I've got a relationship with her, and I can get in her space. I hugged her and didn't say a word. That is therapeutic communication. Now, there's times that I have to talk, but you need to realize that silence sometimes is not, or is never bad for people. Okay? There are so many things that are here on these 2 pages that you've got to read over and look at the examples that's telling you what is therapeutic and what is non-therapeutic communication. What the second one is providing general leads. If you look, what does that really mean? Providing general leads. It's like I want to get them to tell me more information. And that, I cannot say anything else about therapeutic communication except you've got to know that the goal or the reason why we have therapeutic communication is to get information out of our patient. A general leads. Can you tell me how you're feeling? When you ask somebody there, when somebody asks you, can you tell me how you're feeling? Or tell me how about this? That's giving them permission to say, you know what, I'm really bummed out about this. You know, my heart's hurting. You know, and it gives you more information. It helps give you more information of what's going on with that patient. Okay? So as you're looking, when you get ready to do the process recording, you're going to be looking at the communication skills that you said. And when you look at those communication, or the things that you said, you've got to look and see, was that a therapeutic communication skill? If that is, then I need to go figure out what kind of therapeutic communication. Because State Board of Nursing is going to give you a sentence, or give you a scenario, and they're going to say to you, what part of therapeutic communication are you using? Or what skill are you using? And it may be using silence. It may be paraphrasing. So as you look through each one of these examples, this is exactly what you need to know. Is therapeutic or non-therapeutic? Okay? This one is non-therapeutic. If you look on page 474, that is barriers to communication. This is also called non-therapeutic communication. So, non-therapeutic communication, we've talked about closed-ended questions being non-therapeutic, but it's not always bad. But give me, or one of the big, I'm trying to back up a little bit, my brain's getting ahead of myself. Non-therapeutic questions means that you're not getting the adequate information that you need to help meet your goal. In other words, you can't stereotype someone. That is one of the worst things that you can do as far as non-therapeutic communication. Give me an example of stereotyping. What do I mean when you stereotype someone?
So teenagers always drive too fast.
Exactly. So you're taking care of a teenager right now, and he just had a car wreck. And you're going to go in there and say, you know what, I'm a bad glassy teenager drive exactly too fast, or always drive too fast. That is non-therapeutic. It is, men don't drive. And then you've got a patient in here that just lost a man that just lost his wife, and he's in there bawling his eyes out. And you go in and say, you don't cry. That is non-therapeutic. That is not good communication skills. That is not the kind of stuff that I want to hear you say to your client. Because when you think about non-therapeutic communication, is the comment or are the comments I just made going to help me meet the goal of that for that patient.
Demeanor indication.
It is, and it's very, and there's a lot of times I make comments that I'm thinking, oh my gosh, why did I just say that? You know, it's a learned behavior. Is sometimes we don't have a filter on what we say, and there's a lot of times I don't have a filter. Whatever I'm thinking comes out. But as a professional, I have to really truly think about what. It's not about me right now. It is about that patient, and whatever I say is going to influence that patient and the care of that patient, and I can't be going there being judgmental. Another thing when you're communicating with a patient, it is not a good idea to say, I know exactly how you feel. You don't know how they feel. You know, you cannot, there's no way I can look at Chelsea and say, you know what, Chelsea, I know how you feel. I have no idea how she feels right now. Give me another statement you would say when you see someone that is upset.
It'll be alright.
Are you going to say it's going to be okay? Do you know it's going to be okay? Do you want to tell them don't be upset? Because when you say don't be upset, you're not letting them go through their grieving process or whatever they're going through. What would be something good to use when you came in and you saw somebody upset and crying? Yeah, can you tell me why? What's going on? Would you like to talk to me about? At that point, I would probably say, is it something you'd like to talk about? You know, because that is a yes or that's a non-therapeutic, but is the patient's upset? That I'm letting them know that I'd like to help them if I can, and that's an easy question. They don't have to go into any long detail, do they? No, I don't want to talk to you about it.
You're creating a relationship. You're creating a relationship.
Exactly. Exactly. So if they would say, you know, maybe I'd like to talk later, or is there anyone I can call that you would like to talk to? You know, would you please call my pastor? I'll be glad to. Okay? So you're looking at the whole gist of therapeutic communication, non-therapeutic communication is meeting that goal for that patient. What have we established? Now, I will show you your process recording, or if you brought that with you. This assignment is to, I'm going the wrong one. Just to talk about the process recording and this actual assignment is what I'm going to do right this moment. When I was in school, we called it an interpersonal relationship paper. We call it a process recording because what it is forcing you to look at your communication skills. Okay? So with this paper, now, do you think, and I'm going to say this very upfront, do you think the first time you have a conversation that's goal-oriented with your client like this, do you think the whole thing's going to be therapeutic? No. So do not hand me a completely therapeutic conversation because I know that you're lying to me. Okay? That is not, so many people think that that is the reason why we're doing this assignment. It is not the reason we're doing it. What we are trying to do is to get you to look at your communication skills and see what do I need to work on. Okay, so there's going to be, yes, I would love to have every one of you honestly go in and have a therapeutic communication with someone. But I know that it's not going to happen. Okay? And that's not anything wrong with that. It's okay. What we want to see happen is when you do say those non-therapeutic things to your client, you can actually look at it and say, God, how could I have said that differently to have gotten more information from my client? Okay? So that is the goal of this assignment. Obviously, you'll put all of your data right here. Now, you know, one thing is you never write your patient's name on anything, right? You only use initials, okay? So you use your patient's initials, their age, what type of setting are you in? Are you in the hospital room? Where are you? What's going on? The focus of your interaction. We will give you what that focus is as your assignment when you go into the hospital. You got to tell me what you're going to do. What is this? What is the goal of this interaction? And then you describe the patient's appearance. Now, this is going to be a very small interaction with your client. It does not need to be any longer than 5 to 10 minutes. If you sit down and talk to somebody for 5 to 10 minutes, that's a pretty long conversation that you got to write down in it. Okay? But when you go in to talk to this client, you have to remember this is very goal-oriented. So the reason why I'm going to go in there and talk to this client is I'm going to get his feelings about how he feels about being in the hospital. I think that's what the first one is. Okay? Now, your assignment's going to be, when you do this process reporting on your partner, because you're going to partner up with somebody, and you're going to do a 5 to 10 minute conversation with your partner, and you're going to find out from her or him, how do you feel about being in nursing school? Okay, so that's going to be your assignment. How do you feel about being in nursing school? So when you first, and remember it's 5 to 10 minutes. So the first thing that you're going to do is you're going to identify yourself. Hello, my name is Leanne Walker. I'm a student nurse at Rowan Cabarrus Community College. Okay, so I've identified myself. I want to see your verbal communication and your nonverbal communication. So you got to be aware of, what am I doing? Am I making eye contact with her? Did I shake their hands? Did I sit down in the chair to get right on the level with my client? Okay? So you're going to integrate verbal and nonverbal communication. Okay, you with me? Yes, no, maybe.
Yes.
Okay. So, participant 1 is going to be you. Participant 2 is going to be the person you're communicating with for this assignment, for me, but it will be the client in the hospital. Okay? I also want you to see, when you make a comment, you've got to write down what how they responded. Okay? You got to look, did they really look at me? Did they make eye contact with me? So I'm forcing you to look at someone else's verbal and nonverbal communication as well. Okay? So we're just looking to see, how are we communicating? Because my goal, when I talk to Erin, I want to know how she feels about being in nursing school. But then as I'm talking to Erin, she starts telling me all about her 2-year-old who's just into everything, and she can't do anything with him. He's peeing in his pants, he's pooping in his pants. What do I need to learn how to do? I need to learn how to redirect, because how many times do you think you're going to go in and talk to that patient and they're going to go off on a tangent? Okay? Not that I'm going to cut them off or cut them short. I got to learn how as a nurse, because remember, this conversation is very goal oriented. Okay? Very goal oriented. I've got 10 minutes to figure out how you feel about being in nursing school. Okay? Y'all want me to keep going, or you want me to stop me if y'all break?
Let me ask you this question.
You can write dot, 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 because I live here on that. Okay? Because they are one. What I'm more interested in is I want to see how you're going to handle it when they go off. Okay? I gotta get some information out of this paper, and then I need to get out of here. Okay? That's not the way I usually like to go in and out. This assignment, this is all right. That makes sense. That makes sense. Just dot, 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 dot. They're going on and on and on and on and on, and I can't get on the read. All right, do y'all need to take about a 15-minute break before we go on for you to digest this? Okay. You got a what?